Our next speaker, I'm very honored to have. Her name is Dr. Ruth Ladenstein. She's a professor in pediatrics and a senior consultant in pediatric oncology at St. Anna Children's Hospital in Austria. She is head of numerous clinical trials in Europe. She is also a board member of SIOP Europe, and she was also the SIOP president during 2009 to 2012. SIOP currently has 274 active members in 29 countries. She's chair of the Austrian Group for Pediatric Hematology Oncology, and she's a member of the Oncology Advisory Board of the Ministry of Health in Austria, and she's been in that position since 2013. And I asked her to talk about the high-risk trials that are going on in Europe. Dr. Ruth Ladenstein.
Hello, good afternoon. Thank you very much for inviting me. And I'm honored by your interest to learn what we are doing in Europe. And I will try to explain what our philosophy is and which type of trials we are running. So don't hesitate to interrupt me if there are any questions. I don't mind. I think the background on neuroblastoma I don't really need to explain to you. But this is just to point out that this type of survival curves, around flattening out with roughly 30%, particularly in those patients that have high-risk disease, is something we have seen for very long times. And so desperately around the world, I think many teams are trying to improve survival of these children. And the sad story is that we still see 50% of our patients already in metastatic state at diagnosis, with a widespread dissemination either to the bone marrow, lymph nodes, skeleton, liver, but also central nervous system. And with patients above 18 months are at particular risk, and the MYC-N oncogene is one of those identified high-risk factors that drive our therapies, and we identify patients even with localized disease into the high-risk groups, because we know if they receive little treatment, progression is very rapid. Our story in Europe with the high-risk trial that we are still running is a peculiar one. It was actually in 2000-2001 when we got very interested in the antibody. That was when the first results came across from very early trials. And we wanted to have the antibody as part of our European concept. And we had a fundraising actually ongoing through all the European countries at a given time. And believe it or not, with 2 million, we embarked in an adventure which actually ended up in a marketing authorization in 2017 for the European antibody. So it was academically driven for a very long time, up to 2011, till we actually found a company that helped. We have encountered a production failure with the product still in use here in the US in 2002. And this had absorbed some of these fundraised resources. And I found a company actually situated in Vienna called Polyimmune. And they said, well, we are ready to reclone the antibody, but we use another production line. That's all what it is. That's the difference. The one is in myeloma cells, and ours is in ovarian hamster cells, which is quite a standard production line. And so we got a good deal price-wise. So it was really somebody enthusiastic for children, for the disease, and trying to help. Then we had another phenomenon in 2004 in Europe when a new European legislation came through, the Clinical Trials Directive, which changed quite a bit the landscape in Europe, because we needed now an academic sponsor, which means this is not necessarily somebody who has all the money, but is somebody that takes on the full legal responsibility for a trial. And this is quite a complex endeavor when you're working with 25 different European countries, all being under different legislation. So that was a huge challenge for us. And this is actually the reason why we pioneered the amendment of ongoing trials. It's the most amended trial ever, probably. I had a lot of laughs and comments about this one. It's getting more fashionable now with precision medicine, to amend a study rather than to upscale one from scratch, which is a very time and costly process, which delays quite often the start of a trial. So this happened because we followed in a problem-solving approach. As things popped up, we tried to solve them. In 2005, the trial was already running since 2002. We were ready to embark in a phase 1 study because now we had to show if the new product that was produced was tolerable. And also we had to confirm if we can use the same dose as previously used. And this is this quite known schedule of 20 milligram per meter square a day in 8-hour infusion, which we call the short-term infusion, given on 5 consecutive days. So in 2007, having successfully accomplished the phase 1 study, we were finally ready 5 years later, after the main trial already has taken off, to start our original randomization, which is called, I will show you in a minute why it's called R2. This was, I had the idea to compare the antibody arm with an arm where only isotretinoin is given as a standard of care. You know, this is high-dose vitamin A used in the US as in Europe. And we only made it up to 34 patients, and then we amended the trial because one day I walked into a COG meeting when I was president of SIOPEN, and John Maris actually said, Ruth, we have good news. We have a brilliant result. And then I got the question, what are you going to do now? Yeah, so that was gave me a little bit of a headache. Well, we were very happy that immunotherapy was a major success. It is the well-known LCU study. And so we amended in 2009 to a different concept to use our antibody in both arms and combined it with sub-Q IL-2. So a little bit an overview. The randomized trials are still the ones that establish a standard of care. And we are most grateful to patients and families really agreeing to this degree of uncertainty. But you know that we are only asking for randomizations when indeed we really don't know which treatment is better than the other. And in this way, we can learn and establish new and better treatments. Remember that in the background, there's always a data monitoring committee that surveys the data. And as soon as signals come up that there's a real disadvantage for one arm, then such a trial, either for not being able to answer the question or already showing a positive result, will be stopped even prior to the planned accrual. And I show you an example. This happened in one of our arms, and also LSU study was stopped actually early. We have in Europe actually explored an induction regimen. It's called rapid co-check. And it was Andrew Pearson who actually piloted this because he was using the same drugs in a standard schedule, which means every 3 weeks, at a higher dose versus a schedule where the same drugs were given, but every 10 days. So overall, the cumulative doses used in both arms were the same, just the timing was different. And so rapid co-check delivers in only 70 days and was shown to be superior in this randomized setting. Then neuroblastoma is also one of the few solid tumors in pediatric oncology where a lot of effort has gone into exploring if this high-dose therapy is of use for a patient. Because there are other solid tumors where this is still an open and pending question. And so this answer was positively addressed and solved by many groups. So yes, we think it has a major role, particularly in high-risk disease. But there was still this pending question, which one is the best consolidation treatment? And this is the successful LSU trial using the American antibody, which is dinutuximab, which is produced in myeloma cells, and showing this really impressive superiority of immunotherapy. But in the American trial, this is noteworthy to mention, two cytokines, GM-CSF plus interleukin-2 intravenously were used in combination on top of 13-cis-retinoic acid, the high-dose vitamin A schedule. So even having shown these benefits, the investigators still ask questions, but is this really the best regimen, and how can we do better, because we are not yet satisfied what we see. So guiding you through our concept that looks complex. This first question here actually was a supportive care question, because we were using this rapid co-check schedule, but we're asking if we're adding a growth stimulation factor here, a GCSF, if this would be helpful and beneficial. And this is where we embarked, and at that time we had the rapid co-check induction, and we're asking a question on the high-dose treatment. And that's why this is R0, supportive care randomization, and that was our first treatment question in the trial. SEM at that time was largely used in the US, and busulfan melphalan is a European development. So we had used this for a long time, and we had interesting data from the European bone marrow transplantation registry and also early work. And so we asked here the question, which one of these regimens is superior? There's still the need for surgery, a need for radiotherapy, and in this trial, particularly based on old European data where we have seen a 40% local relapse rate, we decided no matter how the success of surgery was, to give 21 Gray to the primary tumor site. And then for a long time, this trial in the early first 5 years only was using 13-cis-retinoic acid in maintenance, since the antibody was not available. And then we started like this first randomization, which we quickly then amended after LSU's result, and we're asking this question of the antibody used in 2 arms and adding IL-2 in 1. And here we have been building on previous experience of giving this interleukin-2 subcutaneously, where we had very favorable experience in a pilot study that it was possible to give this in an outpatient setting with little side effects. So we had hoped that this combination could work very well. And GM-CSF, as used in the US, was not on the market and not available in Europe. So sometimes there are different aspects why you decide for a scheme. There are also practicalities of access to drugs. which is sometimes the reason why one chooses a particular regimen. And the randomization just closed, but with data not yet disclosed, is that once we had agreed to target in this immunotherapy question, we changed the infusion schedule and were giving the antibody as a continuous infusion over 24 hours, over 10 days, but the same dose like in the previous schedule. But I will come back to this. So much for this little bit complex trial. So these are our 24 participating countries in this high-risk trial. You see, it's not purely European, because we have partners, also centers in Australia that participate. Israel contributes quite a high number of patients. Colleagues in Hong Kong and Singapore joined, and there were also negotiations ongoing about New Zealand. This is the total population, which is above target and related to the many amendments that we had between the start of 2002, and which is the reason that this trial for the last question still is open in 2018, so 16 years later. And this explains this high number of patients, which on the other hand is an opportunity. It's a rich data set, not only to learn about treatment concepts, but also to have in the background ancillary studies for biology and other investigations. So the age that we observed is the quite typical age of about 3 years. There is a number of infants included, 167, and those had to be MYC-N amplified, so really were of unfavorable biology. And also in this age group of 12 to 18 years, known to be an age group that potentially could do better. Of 352 patients, so they were either MYC-N amplified or they had other chromosomal aberrations to be and to stay on this trial. So this is a little bit different from the US, where this age group is treated slightly differently. We had a high number, the majority of patients with stage 4 disease, but we also included patients that had this MYC-N amplification. These were 295 patients with localized disease and 26 patients that had the pattern of this special form of infancy neuroblastoma, which has this high potential of regressing with any treatment except if it's MYC-N amplified. And indeed, although some children present with such a clinical picture, if the biology is not right, they need high-dose treatment. So the biology overrules the clinical picture. What do we see if we look into these survival curves? So survival curves are often not so easy to interpret because it always depends very much and when you're looking and comparing results when such a curve starts. So this is from diagnosis, and this includes every patient registered on the trial. So what happens, and this has to be always kept in mind, we do see early progressions during induction. We still see progressions in high-dose treatment. So sadly but true, not all the patients make it up to immunotherapy. So sometimes if you then see curves about high-dose treatment or immunotherapy, it just starts at the time point that patients are actually still alive. And so these curves always look better than an overall curve as such. But nevertheless, if you remember the curve that I shown in the beginning, this was like an earlier data with roughly survival at 5 years at 30%. So the 5-year overall survival, so this would be here, is nevertheless roughly close to 50%. So there is some improvement, although we are still not happy if we look at the overall outcome. So this is overall survival. There is quite a big difference in these patients. So we were happy or are happy to see that the patients at risk with MYC-N amplified localized neuroblastoma and also the MYC-N amplified 4S children are doing quite well in the range between 60 and 70%. But stage 4 disease still is a concern. And if we look at all the patients, even at 5 years, it's down to 32%. And this is mainly covering here the whole period of more than 10 years, and patients receiving immunotherapy are very early on. So this is not really impacting and visible in this outcome curve because here the data will have to mature. So the rapid co-check improvement even in supportive care. That was the question, and it was really interesting. So this is just showing the schedule of the drugs given every 10 days, as I outlined before. And it was really interesting that adding GCSF really did a lot of good to this induction regimen because we saw much less fever incidences, much less grade 3 and 4 toxicities, and in this short schedule, 10 days less in hospital. So that was a real improvement on giving this induction regimen, and that was our standard that we have taken forward. Then we were interested, I'm keeping now with the flow of treatment segments, but I jump in time. That's why we have here now the R3 randomization, because at a given moment we thought, can we do better than with this induction regimen? And we got very interested by the N5 regimen, by the Memorial Sloan Kettering Cancer Center, because they had reported very high response rates. And also in Austria, I have used this for a trial period with very good success. So we thought maybe this could be better, and this was the reason why later on this was amended to the so-called R3 randomization, and the results I have shown actually today at the meeting for the first time publicly. So what was our strategy at that very time point? So this is here the rapid co-check schedule here on top, and here the 5 cycles of this N5 regimen. We asked then how, if the patients achieve a complete metastatic response, if this was the case, so this is clearance of any metastatic site, they would move on to the high-dose regimen of busulfan melphalan. If this was not the case, we are adding 2 more cycles of TBD. It's a 3-drug regimen of topotecan, vincristine, and daunorubicin to improve the response, because we are still believers, or at least have been up to now, that response prior to high-dose treatment is an important factor. And having had stem cell harvest, surgery, irradiation, then there is the phase of immunotherapy thereafter. So what did we see in this direct comparison? And this shows why this is really important. No difference, because in here the capability to successfully complete the induction, that was comparable in both treatment schedules, and in co-check, and this is modified in 7, that's why here's a 7, 95 and 96%. So actually quite the same. And then we had statistically a primary endpoint on event-free survival and one on response. So this is on event-free survival, and you see it's exactly the same. Yeah? No matter what you see, we have completely overlapping curves with patients, 300 patients, 305 in the rapid co-check arm, 312 in the N5 arm, completely comparable outcome data at 2 years. So the data is not yet very mature. The median follow-up is now at 2.1 years, but the data will not change. Response, that was our second endpoint, and you see when we started the trial, we thought there was a complete metastatic response rate of 33%. We were not too happy. We thought we would like to improve it. But albeit there was a response rate reported from the French group with 45%, and from MSK in the beginning 80% response rate. So very exciting. We could not repeat these results and came out with 37%. Yeah. So there is no difference. So what choices did we make after this? This is just the overall survival. Again, overlapping curves, no difference. Overall survival, 70% at 2 years. No difference in the occurrence of relapses, also in non-relapse mortality, which is toxicity. It was balanced between 2 arms because, yes, we do observe early deaths, and the threat is severe infections, bacterial or fungal, because this is a very intensive immunosuppressive induction regimen. So what else do we see in the toxicity scope? If we compare rapid co-check, our standard, against this modified N7 regime using just 5 cycles, we see that N5 has actually globally in non-hematological toxicity a much higher rate. The infection rate was higher, the stomatitis was much more nausea, more vomiting, more diarrhea. So the patient actually had a much higher treatment burden with the N5 cycles than with co-check. So you see where I'm going, I think. If we look into the occurrence rate in each of the cycles for rapid co-check, you see here the percentages that how many patients experienced the grade 3-4 toxicity. So this was a maximum of 22% in the first cycle, but then it leveled out. It has to do with the combination that you give down to 6%. Here, this cycle C again had a higher rate. But looking into the N5 schedule, you see 40% in the first cycle had really a high toxicity burden, and then around 30% in the other ones. So a much higher toxicity rate. So it's quite clear from this that the decision based on this data was taken that we stay with rapid co-check as our standard of care. The high-dose treatment was this question that I mentioned previously, where we were comparing these 2 regimens. So this was in a time when only rapid co-check was open, TVD added to improve response, and the comparison of these 2 regimens. How many patients did we see? Well, this is a little bit about the eligibility. Again, it's high-risk disease, as we previously mentioned. And prior that we are moving patients into the high-dose setting, we are requesting a certain response status from the disease. So we ask that by MIBG in the skeleton, there should be more or at least a 50% reduction in positivity, not more or than 3 positive spots, and in the bone marrow, a complete remission. and obviously enough cells harvested to be submitted to an autologous transplant procedure. So this randomization was open from 2002 till 2010. And interestingly, we have a little bit of a predominance of males in the trial, although not seen as a disadvantage, and the usual age. And interestingly, this trial has hit the significant level prior that we were at full accrual. So that trial stopped early, and we went with this to the plenary session to ASCO, which was unexpected, but underlines the success. And interestingly, for us, in our hands in Europe, busulfan melphalan is superior over SEM in event-free survival and overall survival. So at the plenary session in ASCO, Julie Park was a discussant. This is quite interesting because you present and then there's a discussant just reflecting on the data and interpreting the data. And one of the likelihoods could be we have quite a lot of platinum compounds in the rapid co-check induction. And SEM, again, has high-dose carboplatin. So that could be potentially related that due to growing resistance of cells, that in our hands, SEM is inferior to BUMEL. Yeah, so it's really, you cannot have like only one element and say this is the best. It's ultimately the whole combination of a treatment. So in our hands, the combination of rapid co-check and busulfan melphalan is the one that comes out superior. So this is just showing the results now for stage 4 disease only. So you see, without antibody, we were coming up to 40% at 5 years, but only roughly 30% for the SEM. And the localized disease with busulfan melphalan, almost 80% and 60% with SEM. So these were our results. And then usually you try to run a multivariate analysis just to see what type of interaction you have between factors, and these models usually show you an independent action of a risk factor or of a drug combination. So looking into this in our model 1, when we looked in all the patients, we saw that busulfan melphalan was of independent superiority. Obviously, the localized stages are doing much better. And we are seeing here also a significant disadvantage for the older children, but this is also known. Yeah? Once your one is above 5 years, the prognosis is worse than for the younger ones. And we keep here also the response as an important factor, that patients achieving a complete response prior to the high-dose transplant are doing better than those that still have residual disease in their body. And when we only look into the stage 4 disease patients, the factors basically stay the same. The only that we add on is a very early factor, and it has to do with disease load. So if you just have one metastatic compartment, that means either only bone marrow or only skeleton or only lymph nodes, then you have a better outlook than a combination of multiple sites. So that's what this means. And we have the toxicity profiles of these two regimens are different. So for the majority of side effects, not only hematological, but particularly in terms of infection, stomatitis, nausea, vomiting, but also central toxicity, busulfan melphalan is superior, also in our hands in terms of ototoxicity. But busulfan-melphalan has one nasty side effect, and this is that it interacts with the liver, creating what is called veno-occlusive disease, which is one of the hallmark toxicities of busulfan-melphalan. Which is in the majority of cases and patients manageable, but is a risk. So this summarizes here the toxicity profiles and this significant higher burden with the SEM, except for this VOD that occurs in 22% of the patients treated with busulfan-melphalan. We have a grading for the disease, and those children that are really a worry are those with the grade 3, and these are only 4%. So we still consider this manageable, knowing this side effect. And there is a drug out there that is given in combination, difeprotide, but this is one of the supportive actions, apart from others, that one can take. So now I would like to show you some of our experience with the use of antibody in Europe in the respective treatment periods. Like in the US, we have treated a lot of patients. It's over 1,000 patients. So I think we have accumulated really a lot of knowledge in the US and in Europe. And this shows you these episodes. These are here my first 34 patients that we treated on the trial, where we had then to stop. The red period is what we refer to the R1 period. This is the short-term infusion schedule. Then you see here some green, and this refers to a period where the company with which we have been working at that time was very generous. Although the randomization was closed, we continued with the less toxic arm, and were giving antibody only in this interim period. And then we, on the basis of the data, asked the question to nevertheless continue to ask an IL-2 question, but with a long-term infusion schedule and half the dose of IL-2. So what are the results of R2? So this is the way the schedule looks like in Europe. We give 5 cycles of chimeric 14/18 CHO called dinutuximab beta. The reason why it's not exactly the same has to do with the production cell line and then glycylation, which make some actions nevertheless different. So although the antibodies are very much alike, we consider them not being exactly the same. And here you see the schedule. We start out after radiotherapy with 13-cis-retinoic acid. Then there's the first week of sub-Q IL-2. And in the week thereafter, the antibody in combination with sub-Q IL-2. And the other randomized arm gets the antibody, but without IL-2. These are the treatment periods for the reason of clarity highlighted again. From 2002 till 2010, we had this high-dose question. And then when we were able to open this immunotherapy question, the trial was running from 2009 till 2014. So there are some overlaps between the 2 randomizations, but rather marginal. So these are our results at 3 years. And again, you see somehow we just seem to produce these results with overlapping curves. So that's easy to remember. But the message is most important, because when you look into this schedule, then you can conclude that you don't need IL-2. At least we conclude in this trial that antibody alone is as effective for event-free survival And why did this happen? There's a lot of logic behind in terms of stimulating the immune response with NK cells through IL-2. So we were quite convinced by our earlier studies, and particular with a trial that we have undertaken with the sub-Q IL-2, as I previously mentioned, where patients were happily outpatients with a little bit of fever. And we did not expect that much interaction as encountered later on. So the metastatic compartments made also a difference in the immunotherapy. And you say when you now observe patients that have gone through the treatments up to the time point where they were able to go on antibody treatment, you can produce now outlooks and curves which look much better. And if this is a patient that at diagnosis actually only had one metastatic compartment, the outcome can be as good as 76% at 3 years. So this was I go back one. Oops, can I go back one? Here we are. I was talking about the response, and this is also something worthwhile to mention. This now looks at the response status prior that the patient goes on immunotherapy. And again, you see the patients in a complete remission are doing much better. At 3 years, 64% are event-free alive. Very good partial remission, by definition, patients that have a small residue on the primary tumor site. So they level out to about the same by the end here of the curve. But partial remissions are doing less favorable. But it's interesting that these patients nevertheless have a 40% plateau and benefited from the antibody. And what we have seen, I'm not sure if I have the slide in, is that we are seeing a very high response rate with the antibody in those patients that still have residual disease, about up to 50% actually, which means the drug is highly active. And even after the high-dose transplant, antibody acts at really a high therapeutic index. Why we don't like sub-Q IL-2 so much in this context, this is what this graph is showing. A typical side effect of IL-2 is fever. So you see if we give it, 40% of the patients have fever as opposed to 14%. They are generally less well, with 40% being grade 3 affected versus 16% if you give the antibody alone. There's a higher infection rate. Interestingly, hypersensitivity reactions, which are well known for the antibody, are more pronounced if you combine it with IL-2 as urticarias and also a leakage, capillary leak syndrome and cytokine release is more pronounced if IL-2 is added. And interestingly, we know that when we are giving this antibody, we need high doses of morphine because there is a related pain to it. These pain reactions, even under high-dose intravenous morphine, are higher if it's combined with IL-2. So this is quite a burden, and you need to have convincing evidence to keep on going with IL-2. This is just a summary of what I just said. Again, on the right side, all the side effects that are more pronounced with sub-Q IL-2. So the question that we asked ourselves, and this was for us difficult in Europe to answer, if we have improved the outcomes in with our trial strategy when adding on immunotherapy. And so the only way to solve this question was something which is statistically not as sound as a direct comparison, but we established a historical control referring to patients prior that the antibody became available. And so this is just to demonstrate the treatments that were given, and we established a group of 466 patients that were part of the high-dose randomization, and 378 patients of the immunotherapy era to compare the outcomes. So the observation time in the historical control group is slightly longer, with 8.6 years. In the radioimmunotherapy group, almost 5 years. And so we ended up with a population of 844 patients to study. We equalized them for a number of parameters to have comparable patients. So they all had not more than 9 months between diagnosis and the start of the high-dose chemotherapy. They had to have at least CR, VGPR, or this partial remission prior to the high-dose treatment, and no progression by 109 days following the high-dose treatment. And this was the median interval that we saw in the immunotherapy group between high-dose treatment and the start of immunotherapy. So we tried to mimic and establish the same criteria for those patients that have not received the antibody to be able to compare. And this is the outcome, and this was also shown at this meeting for the first time. And indeed, with this statistical exercise, we are able to show that immunotherapy at 2 years it achieves an event-free survival of 65% versus the historical control group with only 50%, and in overall survival, this reads out for the historical control with 69% and 77%. And you see the results, the observation is quite long for quite a number of patients. So this is all these little marks here are actually patients as they go along and observed longer and longer. So the curves are quite stable and and it looks as if they would not level out by the observation time that we already have. And then you ask a question, how to control the number of risk factors that I previously mentioned, which is age and these metastatic compartments, adding on these additional treatments of TVD, the status, and obviously the high-dose treatment concept. And again, in this multivariable model, we have an independent prediction of a more favorable outcome for the immunotherapy randomized population. So this is what this multivariate analysis shows, and we are keeping risk factors like the older age, more than one metastatic compartment, and a PR status, partial remission, only pre-immunotherapy, and again, that busulfan is better than SEM. And we were then nevertheless interested if the antibody works in BOOML as well as in the SEM patient, and we're running 2 parallel analyses, and the message here given is, yes, it does. Interestingly, we have observed a stronger effect. This is expressed here by the hazard ratios for patients treated with SEM and antibodies, so they benefited more than the patients with busulfan melphalan, but both groups significantly improved their outcomes with antibody treatment. And this is now interesting and maybe for parents reassuring. No matter where you live, in the US or in Europe, although we have different approaches, we have almost comparable results, yeah? Although some treatment philosophies behind are slightly different. So this is the LSU New England paper, standard treatment with 13 cysteine retinoic acids in maintenance 46%. This is our historical control with 54%. And immunotherapy arm, the 3-drug regimen, 66% in the US and 68% in Europe. But nevertheless, with this promising message that half of the patients have only received antibody alone and no additional cytokine. So a few words to finish up with the long-term infusion schedule that we are currently exploring in relapsed refractory settings and also in the frontline setting. That means we are giving the antibody as a continuous infusion over 10 days. And here you see with the red arrows IL-2 in the first week given, and in the second week it's now every other day, and in total only half the dose. So we have accrued the last patients, but the results are not yet disclosed. And I think once we see the results, we have an answer if IL-2 will be used in the future or will leave the field. So this just shows all the accrual is done, and these were the last patients early in 2018, and the data now needs to mature.
Ruth, we
Yes?
have to move pretty quickly. We
Yep,
have one more speaker yet, sorry.
Thank you for reminding me. I'm actually at the end. We are now just in an interim phase on maturing our data till our next trial opens, and this is very much aligned with what you're doing in the US. Double transplants that have the potential to improve even further. This is Julie Park's data showing the advantage of the double transplant shown at ASCO last year. And this is what we in Europe will do equally. We have another induction question, but also running a double transplant regime with different drugs, but adding on as you are doing in the US, and the rest is probably today of not so much interest. And for poor responding patients, we are driving them into an MIBG-driven double transplant, whereas also a double transplant with high-dose FIOTHEPA, again in a philosophy to improve the results. So the trial has given us a lot of lessons in terms of induction, consolidation, and minimal residual disease treatment, as I explained. So this is actually all that I have said, and this is my thanks to my cooperative group. So thank you very much for your attention. This was a long story. Sorry for keeping you. And I hope that I have increased your understanding on what Europe is doing.
Okay.
As
Thank you very
US.
much. Does anyone have any questions? Okay. Oh, okay. I think we're good. All right, one? Yeah, one.
Might be the only person here from Europe, so I might as well. You spoke a lot about the frontline treatment and the improvements that you're trying to achieve. I didn't hear a lot about treatment for children that relapse. There are a lot of things that are being done in the U.S. because you mentioned that there's a similar. There are similar results, but in terms of approaches and different therapies, I seem to see that there's a lot more being done here than. But obviously, there are trials in Europe that I know of that you didn't mention. But nevertheless, could you tell us if you think that we are on the same plateau in terms of response to relapses and refractory disease?
I think there are a number of studies that I have not addressed today. You're completely right. Yeah? So there is innovation ongoing in combination with MIBG treatments. You might have heard about this cooperative trial with minivan combining the antibody and PD-L1, which is a concept. There are trials out with newer drugs, which is the RISK trial, there's the Beacon trial. And there is a certain degree, obviously, about access to drugs, but I think with the ITCC, you probably heard about it, there's a lot of innovation now going on in early trials, cross indications.
Sorry, can I just say something? I've heard about it, and the other difficulty that we have is looking at that picture right there. You know, there are a lot of countries in Europe. Not all of them have the same access to the same treatments and trials. And I come from Portugal, and for some reason, SIOPEN doesn't work there as it should. I've addressed this issue, but that's another for another time. But yeah, it's difficult to get people together and have us all basically have access to the same things and. But that's just that.
I mean, you're talking to the right person, because you probably heard about European reference networks, yeah, and we're also driving in pediatric oncology the European reference networks, which exactly addresses the question of cross-border healthcare, so that eventually you can go cross-border if for one reason or another the access is not available in your own country. But that's a different topic. Yeah, I think here we are not on the same level across Europe. You're completely right. Yeah, for different reasons.
Yeah.